This program is brought to you by Emory University.
All right, well, good morning, everyone, and welcome to our second Emory Heart and Vascular Grand Rounds. I'm Gina Lundberg, the director of the Emory Women's Heart Center, and it is my deep pleasure to present Grand Rounds this morning. Present the presenter, Dr. Garima Sharma, has been a dear friend and a huge leader in women and heart disease, particularly in the area of pregnancy and pregnancy complications. She is currently an assistant professor of medicine in the Division of Cardiology and the Ciccarone Center of Prevention for Cardiovascular Diseases at the Johns Hopkins University School of Medicine. Her clinical and research interests are in cardiovascular disease in women, especially pregnancy, preeclampsia, maternal obesity, health disparities, postpartum prevention of complications from hypertension disorders of pregnancy. She sees high-risk cardiovascular problems such as valvular heart disease, coronary and aortic dissections, coronary artery disease. And she sees patients in the postpartum cardiovascular clinic for cardiovascular health assessment, future pregnancy counseling, and routine cardiovascular care. Additionally, she's involved with education of fellows and residents, and she is on the ACC Women in Cardiology Leadership Council and a huge contributor there. She is the co-author of the American Heart Association Scientific Statement on Cardiovascular Considerations in Caring for Pregnant Patients. She has written many articles on cardiovascular disease in pregnancy, gender equity in cardiology, mentoring and career development for fellows in training, and early career in the American College, in the JACC Journal. She's also the section editor for JACC, and she's led several national initiatives for professional development, and she is the governor-elect for the Maryland chapter of the ACC. I think there's only 5 women governors for the chapter, so it's an outstanding honor to have her with us today. So I will now turn it over to you, Dr. Sharma.
Thank you, everybody. This is a huge honor to be here, even though it's remote. You know, if you're to look at Emory, you know, from the point of view of women in cardiology, this is the mecca of women's cardiovascular health. You know, this is where we were watching, the world watches what comes out of the center, has been watching for the past, you know, 2 decades, and it's a huge honor as a woman in cardiology, as well as somebody who's interested in cardiovascular disease in women, to be able to present to this wonderful audience. So I can't start a talk without recognizing 2 very pivotal women who've had a big contribution in cardiovascular disease. And not just that, but also pivoting women into the forefront of cardiology. And one is the Queen of Cardiology, which is Nanette Wenger, who celebrated her 90th birthday. But for my institution, it is Bernadine Healy, who has big similarities with Nanette, and you know, was a real tour de force and led down many foundational trials through the NIH that were specifically looking and interrogating at cardiovascular disease in women and sex and gender specific problems. So it's a huge honor. Similarities between Hopkins and Emory. Also similarities between, you know, one of your hospitals and the Johns Hopkins Hospital, splitting images of each other. And the fact that we both the city of Atlanta and Baltimore have teams named after birds. So, you know, go Ravens. I know that the Falcons had not such a good weekend, but hopefully they'll bounce back. If I were to frame this question of our Grand Rounds today, is what are the take-home points of this talk? We know that for the last 4 decades, cardiovascular disease trends have declined, but they have not declined consistently in all populations. In fact, acute myocardial infarction is on the rise in younger women. And what's important to know from the field of cardio-obstetrics is that cardiovascular disease is the leading cause of pregnancy-related maternal mortality, and has really evolved as a real problem for women that are getting pregnant. And, you know, adverse pregnancy outcomes such as preeclampsia, gestational hypertension, preterm delivery, small for gestational infants, are associated with significant both short-term and long-term cardiovascular events. And whether that is because of a change in the maternal population or the maternal health, I think both of those are contributing factors. And the field of cardio-obstetrics now focuses of not only just treatment of cardiovascular disorders in pregnancy, but also prevention, early detection, optimal treatment, as well as management of these women postpartum, which was a huge population that cardiologists were not seeing before. But it's really important to take note that improving cardiovascular workforce competencies in cardio-obstetrics is an unmet need. This is not an official topic in the COCATs. It's not recognized as a topic in the COCATs and should be. But our training and healthcare policy should really urgently implement strategies to improve awareness, education, and health promotion of these young women. And so this is really the crux of my talk today. I have three main objectives. One is to discuss maternal mortality, racial disparities in maternal mortality and pregnancy-related deaths. What have been the trends in cardiovascular disease and pregnancy hospitalizations in the last 2 decades, and why is this important? And also then focus on adverse pregnancy outcomes and their long-term associations with cardiovascular risks. And then focus on development of competencies in cardio-obstetrics and what do we need to know. So much of what I do as an academic clinician is about patients. And so I'd like to start off with a patient's case. This is a lady that was sent to me from her primary care doctor with a diagnosis of peripartum cardiomyopathy, who had had a challenging, years with pregnancy and pregnancy-associated problems. And she was already on guideline-directed medical therapy with metoprolol and lisinopril, and was coming in with very specific questions about subsequent pregnancy. And when I took her history, a very detailed pregnancy history, I recognized that at 22, she was admitted with preterm labor when she was about 34 weeks and delivered a small for gestational age infant. She was lost to follow-up and came back a few years later, and this time in her second pregnancy had preeclampsia, which necessitated a preterm delivery again, this time at 34 weeks. Both her babies were fine and okay postpartum, and then came back another 3 years later, this time with severe features of preeclampsia. And we'll talk about that in a bit, but also had to deliver her baby at 38 weeks, and then was lost to follow-up again and came back about 4 months later with acute decompensated heart failure and a new diagnosis of peripartum cardiomyopathy. So when she came to me in her clinic, her questions to me were, is my cardiomyopathy preventable? Or, were there some signs? Will I need to be on medications for the rest of my life, or will my cardiomyopathy improve? And what are my cardiovascular risks? And while she was talking to me, I couldn't help thinking that this lady was telling us that something was wrong with her for a really long time. And we just were not able to see it. And that's the sad part about this, and maybe also a learning edge for all of this. The United States has the highest maternal mortality of the developed world. Maternal mortality is a hard public health indicator. It's one of those few metrics that are used to look at a public health system. It's just as important as the GDP, in my opinion. And when we really compare ourselves to the rest of the developed world, we're not doing so well. And while the global maternal mortality is declining, maternal mortality in the United States has actually risen in the last 2 decades. And there are several reasons and several contributing reasons for it. But the truth is that we've made great strides in reducing maternal deaths from hemorrhage or eclampsia or embolism. So why is that our maternal mortality continues to rise when we have now specific bundles and specific ways to reduce maternal mortality? And so it's important to recognize that advanced maternal age, as well as the contribution of adverse pregnancy outcomes, is a significant burden in these women. And we really have to look at this data closely to understand the gaps in care, the disparities in care, and maybe work together to improve that. And so one can't talk about maternal mortality in the United States without recognizing the huge and the stark disparity, and actually really unacceptable disparity, where a Black woman in the United States is about 4 times more likely to die of pregnancy-related problems than their white counterpart. And this kind of disparity persists across all educational levels and even after controlling for household income. And the truth is that Black women are more likely to have gestational diabetics or to be gestational diabetics or preeclamptics, and that contributes significantly. But it's also important to recognize the underlying implicit bias in care and the disparities. And I think recognizing social determinants of health and how they contribute to pregnancy-related mortality is a really important problem. When we look at causes of pregnancy-related deaths, this is data from the CDC, which is looking at cause-specific pregnancy-related mortality. A deeper dive into the data tells us that cardiovascular disease, cardiomyopathy, and other cardiovascular conditions, such as pulmonary hypertension, adult congenital heart disease, SCAD, aortic dissections, if you really tally all of this out, it is beyond any other contributing factor to pregnancy-related death. And that's the real important point to recognize. Cardiomyopathy, cardiovascular disease, and other contributing factors are leading to huge morbidity, severe maternal morbidity and mortality in this age group. And this is, again, data from the Hopkins School of Public Health by my collaborator, Andrea Krianga, that looked at pregnancy-related mortality in the United States from 1987 to 2013. And this is population-level, cost-specific, proportional pregnancy-related mortality. And what's telling us is that over these years, while we've gotten really good at treating hemorrhage and hypertensive disorders of pregnancy and infection and pulmonary embolisms, we're not very good at treating cardiovascular complications. In fact, those have risen. And those are contributing to significant morbidity now. This is startling data. So why are women dying? And what proportion of these cardiac problems that they're getting during pregnancy and the cause-specific mortality from cardiovascular disease, how much of it is preventable? And this is data from maternal mortality review committees that pours into the pregnancy surveillance system. These are 9 maternal mortality review committees from Colorado, Delaware, South Carolina, North Carolina, and Hawaii. And when you look at what portion of deaths from cardiovascular causes are preventable, close to 68% are preventable, which is really striking. And so when you do a deeper dive onto the contributing factors for pregnancy-related deaths, there can be divided into community problems, patient problems, provider problems, facility problems, and systems of care. And when you look at the provider factors, delay in diagnosis, ineffective treatment, misdiagnosis, and ineffective referrals are the primary causes, which is just startling because this is telling you that there is a knowledge gap, there's a recognition gap, there's an action gap. And I think that that is something that needs to change if we are to drive these factors down. In terms of systems of care, poor communication between referring doctors and specialists was identified as one of the reasons why there could have been increased maternal morbidity and mortality. And then there are patient and family signs where the patient really don't recognize their warning signs and don't have the ability to recognize the need for care. So definitely something to work on as well. So what are the timings of these maternal deaths? When are they happening? A deeper dive into the maternal deaths, again, data from the School of Public Health at Hopkins, that is looking at when are these women dying. And so if you really look at it, most of the data will tell you that women are either dying before they are in the hospital, or before delivery, or they're dying after delivery. And if you really look at the data from cardiac specific point of view, and I'll talk about it a little later, most of the cardiac contributions occur late after pregnancy. And so this is important to recognize because Medicaid only covers women for about 60 days postpartum. So if you were to have a cardiovascular problem or a disease-specific problem during pregnancy and you lose your insurance after 60 days, you really have an access to care problem, which could be contributing to your maternal mortality. This is again data from the CDC that looks at pregnancy-related deaths. And what they found, that when you stratify these deaths with the timing of when it's happening, while early in pregnancy, during pregnancy and delivery, most of them are dying from obstetrical complications or postpartum hemorrhage or hypertensive disorders of pregnancy. The data that really startles everybody is what's happening to them postpartum. So about 7 days to about 365 days postpartum, the relative contribution of cardiovascular problems leading to death is higher than any other. Again, forcing us to recognize that Medicaid expansion, access to care issues, social determinants of health, education, health promotion in this time frame is extremely important. There has been a recent advisory, joint advisory from AHA as well as ACOG, really understanding postpartum time frame as an important time frame and extension of pregnancy as the fourth trimester, so that these women are not lost to follow up and are really seen by physicians, clinicians, so that their risk factors can be mitigated and their health can be improved. So moving from maternal mortality and pregnancy-related causes, if you were to look at the trends in pregnancy hospitalizations from cardiovascular disease, it becomes clear that while women get pregnant during pregnancy, their most morbidity and mortality is caused by congenital heart disease and valvular heart disease. These trends have worsened over the time frame. This is data from 2002 to 2012 that looked at delivery hospitalizations from the national inpatient sample and looked at the percentage increase of hospitalizations of cardiovascular disease. That increased by 25% in the time frame, and major cardiac events in these women also increased. But what is also important to notice is that the rates of hypertensive disorders of pregnancy also increased during that time frame, and so did preterm birth and small for gestational age infants. And if you can recall, my patient had 3 subsequent pregnancies with preeclamptic deliveries and preterm deliveries in a very short time frame from the age 22 to 28. Kind of something for us to sort of recognize, and it also helps us recognize the importance of taking a really good pregnancy history in these women. So where is the field moving right now? And this has been a paradigm shift in how we think about cardiovascular disease in pregnancy. And while yes, disorders of the heart and vascular system, such as congenital heart disease and pulmonary hypertension, coronary artery disease, pregnancy-associated SCAD, venous thromboembolism, diseases of the aorta, cardiomyopathies are still significant contributing problems during pregnancy. Recognition of adverse pregnancy outcomes and recognition of the contributing factors of adverse pregnancy outcomes, such as maternal age, hypertension, existing obesity, existing dyslipidemia prior to pregnancy, pre-pregnancy insulin resistance, is now leading for physicians and clinicians and providers to really recognize APOs as a significant problem, which doesn't end with pregnancy and actually extends into their life. And so this is my area of research where I focus a lot on health education, promotion, understanding the risks and the trends overall. So what are adverse pregnancy outcomes? This is a cluster of a constellation of different diseases, which actually have shared pathogenesis, and we'll talk about that in a bit. But these are, types of APOs or preeclampsia, which is development of hypertension of 140/90, about 20 weeks on with the presence of multi-organ involvement, gestational hypertension, which is not such a benign sister, but sometimes accompanies preeclamptic pregnancies, preterm birth, intrauterine growth restriction, and the more malignant form of preeclampsia, which is associated with consumptive coagulopathy, increased liver enzymes, low platelets, very atypical and very catastrophic malignant form. But I also want to make a point about peripartum cardiomyopathy, which our patient had that developed after subsequent pregnancies with preeclampsia, and we'll talk about the associations of preeclampsia and peripartum cardiomyopathy in our talk as well. So broadly, hypertensive disorders of pregnancy are 4 major types. These are women who can have chronic hypertension that develop preeclampsia during pregnancy, or de novo, new preeclampsia or eclampsia, or gestational hypertension. This was given a major focus in the new AHA consensus guidelines, the consensus statement that came out on cardiovascular care in pregnancy, and it's something that cardiologists ought to know. But, you know, in terms about what are the maladaptive changes in preeclampsia and what changes in the physiology of this patient that could maybe give us a window into what's happening subclinically during this time frame, and perhaps also give us an idea of what could have changed in the postpartum time frame. So in preeclampsia, there's an impairment of every single organ system, and the severity of the impairment really is directly proportional to the pathologic manifestation. So while we know that cardiac output increases during pregnancy, there is an impaired hemodynamic adaptation where your mean arterial pressure, systemic vascular resistance, and cardiac output does not increase proportionately. And that has effects on the myocardial function, and I'll talk about that in a bit. But in addition to that, renal, metabolic, and hematologic systems are all affected in such that there is a decrease in GFR, increased proteinuria, increased insulin resistance, and increased subclinical activation of the coagulation system during preeclampsia, leading to its severe pathological manifestations. We often get asked in the echo lab, so what are the physiological parameters in pregnancy? And so what are some of the things that are normal for pregnancy? And it's important to recognize that while there is a pathological change in preeclampsia, there's a lot of normal physiological changes that occur during pregnancy. And we looked at this in our center. We looked at the studies from about 22 different regions looking at normal changes in echocardiograms in pregnancy. And we've tabulated few physiological changes that happen during the mid to late third trimester that I have put in here, while there is changes in the anatomic changes such as left atrial dimensional changes, left ventricular dimensional changes, all to kind of compensate for the increased cardiac output, which increases about 30 to 50%, increased plasma volume, increased sympathetic activity. We should recognize that generally the parameters that lead to deformation, such as LV strain and tissue Doppler velocities, which are indicative of myocardial dysfunction and diastolic dysfunction, don't necessarily change. And these physiological changes then will revert back to normal. And this is data from our center that looked at 100 pregnancies with severe preeclampsia with severe features, which is women who've had preeclamptic pregnancy with blood pressures greater than 160 over 100, and 10 associated with evidence of multi-organ failure, such as pulmonary hypertension, renal dysfunction, convulsions, seizures. And we looked at the changes in acute cardiac, diastolic, systolic, and deformation parameters. And what we found is that every single deformation parameter related to a right side and left side change, except for maybe a slight, no change in the strain parameters. But we also found that the mitral E prime velocity, which I alluded to as being a tissue Doppler velocity indicator of diastolic dysfunction, actually decreased acutely. So this may point towards the fact that women with severe preeclamptic pregnancies can have acute diastolic dysfunction. This cohort is now about 4 years out. We're bringing them back to look at whether these parameters persist in those women who've had preeclampsia, independent of whether they develop chronic hypertension or not. A little bit about why APOs happen and why preeclampsia happens. So recognizing the cause of preeclampsia, or perhaps the real pathogenesis of preeclampsia, may help us sort of identify the higher risk women and sort of lead to implementation of changes that can prevent their course. And so it's now widely recognized that the impairment is in the placenta. The problem is in the placenta, and there is a key pathophysiological change in the placental spiral arteries that happens in preeclamptic pregnancies that doesn't happen in normal pregnancies. While the normal spiral arteries of a normal placenta are deep and they penetrate deep into the myometrium and they're vasodilated, for whatever reason, whether it is because of oxidative stress, genetic factors, other factors, immunological problems, underlying cardiovascular disease, the spiral arteries of a preeclamptic pregnancy are small and they're narrow and they're shallow, and that leads to incomplete vasculogenesis. And that what that does is causes an impairment in the anti-angiogenic milieu. And what we recognize that SFLT, which is a form of soluble form of tyrosine kinase and is an inhibitor of placental growth factor, increases. This SFLT and placental growth factor ratio has been identified to be associated with the profound manifestations of preeclampsia, and is also the area of my research. Basically, placental growth factor is required for angiogenesis and for the spiral arteries to grow and for the endothelial function to be normal. And when this SFLT increases, it sort of inhibits placental growth factor and increases vascular endothelial growth factor and causes decreased placentation, perhaps, and leads to these profound effects. And, there has been a lot of data recently that looks at this SFLT placental growth factor ratio and the cutoffs that can be used as predictive of ruling out pregnancy. It has a very strong negative predictive value, and is, there's more research coming out in this field, but this paper that came out a few years ago in the New England Journal of Medicine that looked at the predictive value of this SFLT placental growth factor ratio as a biomarker test that can be done earlier in pregnancy, about 12 weeks out and onwards, that can be strongly associated with predicting who's not going to develop preeclampsia when they have high-risk features at baseline. So what are some cardiovascular risks associated with pregnancy? And this is a beautiful paper that came out by one of my mentees from Johns Hopkins that looked at associations of all of these APOs, very strong associations, not just beyond 10 years with all kinds of cardiovascular disease, hypertension, stroke, mortality, but also strong associations less than 10 years. And that's really something for us to sort of delve on. And again, this is data from the UK, which is, very important to recognize. This is a very large meta-analysis of 22 studies, more than 250,000 women that were followed from 6 weeks onwards to about 39 years. And what they found was that preeclampsia was independently associated with cardiovascular death, increased coronary artery disease, increased heart failure, and increased strokes. And even in your sensitivity analysis, after controlling for age and for body mass index, this kind of independent association continued. But of particular note is that while it is associated greater than 10 years with all different types of cardiovascular outcomes, the impact that preeclampsia alone has in less than 10 years of an index pregnancy, which is Our Lady, 28-year-old who came specifically asking me for her short-term and cardiovascular risks. This is something that we need to recognize, is that association is even stronger if it's less than 10 years since preeclamptic pregnancy, perhaps because some of it may be attenuated by development of other maternal and cardiovascular traditional risk factors. So this is something that we can educate our patients about once they've had a preeclamptic pregnancy, so what their long-term cardiovascular risks are. This is also data that came out recently in the JACC from the Brigham group that looked at the UK Biobank. And along with what we know of hypertensive disorders of pregnancy being strongly associated with coronary artery disease and heart failure, this group also found that premature aging, premature aortic stenosis, valvular degeneration, and arterial stiffness was also strongly associated with hypertensive disorders of pregnancy, something to sort of educate our patients about as well. And what about preterm birth? Because Our Lady had multiple preterm births, and she came in asking specifically about her APOs. This is again data from Pensy Vu that looks at preterm delivery. And depending on the timing of preterm delivery, this is now being widely recognized. It's not just early preterm, but even late preterm are both strongly associated with cardiovascular death, stroke, and coronary artery disease. And this is the paper that recently came out, very recently, I think in August, from the Mount Sinai group that looked at a cohort of Swedish women. And these women were followed for about a total of 43 years. There were 2 million pregnancies. And they were trying to really tabulate the difference between extremely preterm and early preterm. And you can look at what their definition of extremely preterm was: 22 to 27 weeks, very preterm, late preterm, early preterm delivery, and compared it to full-term delivery, which is 39 to 41 weeks, and then looked at the adjusted hazard ratio of associations with ischemic heart disease. And earliest preterm delivery and extremely preterm delivery was strongly and greatest and associated with developing ischemic heart disease in 10 years. So this is actually really valuable data that is now telling us that preterm delivery, in addition to preeclampsia, which is recognized as sex-specific risk-enhancing factor of premature coronary artery disease and cardiovascular disease, is also something that we should be incorporating in our counseling for our patients with these problems. So, you know, I'm a Game of Thrones fans, and I have to sort of insert some wisdom from the Game of Thrones. And the truth is that the only true wisdom is that you know nothing. And the fact is that we do know that adverse pregnancy outcomes are associated with long-term cardiovascular risks, but we don't know whether they cause it. So there is a strong association, but there is no causation yet. And that is really the million-dollar question. We've known from other prior papers that when you actually incorporate hypertensive disorders of pregnancy on top of traditional risk factors to predict if that is sort of altering their atherosclerotic cardiovascular risk, that data does not pan out. So it does not really improve the discrimination of these adverse pregnancy outcomes as leading to a specific problem on top of underlying cardiovascular risk factors. And so I think there is still more data needed as to what to be done, what is to be done, how to best incorporate APOs in our risk counseling. Do we need to really design different data sets and prospective data that look at women that are younger? So these are some real gaps in knowledge, and something that, you know, I think will lead the field forward, whether an APO causes increased cardiovascular risk or it's something that's merely uncovered during a pregnancy, and what is the signification. And it may be really important to establish if the APO itself causes the risk, or it's so that we can make an early intervention. What are some of the things that we should be looking for? Are there some biomarkers that we should be checking? Is early discovery of subclinical cardiovascular disease and dysfunction help us in some way to inform clinicians to allow for early identification? Are there any clues in the placenta? Does the placenta inform us as to what to look for? Understanding this link may help identify some women earlier and may help implement some strategies that may change the course of these women. So if you can remember, one of the questions that my lady asked me is, can we prevent APOs? And the answer is yes. To an extent, we can. And this is data from ACOG. In fact, the ACOG and the Society of Maternal Fetal Medicine actually supports the use of aspirin in these women starting 12 weeks on during pregnancy, about 28 weeks. And it's really catered towards the women who are at high risk of developing preeclampsia, such as the women who've had early preeclampsia or have had preeclampsia in previous deliveries, like our patient, type 1 or type 2 diabetic. Autoimmune disease such as lupus or rheumatoid arthritis is a high risk feature. Chronic hypertension, women who have existing hypertension and then subsequently get pregnant should be considered to be on aspirin unless they have a contraindication, and the ones that have renal impairment. The data is not quite robust as to what to do in the middle group, which is the nulliparous or the multiparous women, or women who are obese, who've had a family history but no personal history of preeclampsia, African-American race, prior APOs which are not preeclamptic, for example, preterm birth, or have had large intervals between their pregnancy, but they're all considered as risk enhancers, and some obstetricians and MFMs will consider putting these women in the middle group on aspirin as well as a preventative therapy. Of note, Our Lady was not on aspirin in her first 2 pregnancies. And then moving on to the other section of the talk, which is what is the association of APOs, particularly preeclampsia, and peripartum cardiomyopathy. And this comes up a lot in clinical practice as to which women with preeclampsia can develop peripartum cardiomyopathy, or what are the associations. And what we do know about peripartum cardiomyopathy, that it's a new onset heart failure in the last month of pregnancy to about 5 months postpartum in the absence of any identifiable cause, with an LV systolic function of 45% or less, with or without LV dilatation. And now we have had some studies that look at this S-FLIT, placental growth factor ratio that I was talking about, being elevated in very late pregnancy and sort of associated with the timing of developing peripartum cardiomyopathy. And so there are some shared mechanisms because there are some very, shared risk factors. And so extremes of age, multi-fetal gestation, anti-angiogenic factors, smoking, and oxidative stress are all risk factors associated with preeclampsia as well as peripartum cardiomyopathy. But it must be recognized that there are 2 separate diseases, and though they have overlap, 90% of the women who have preeclampsia actually do not develop peripartum cardiomyopathy, and only about 50% of the women who've had peripartum cardiomyopathy may have preeclampsia or gestational hypertension as well. So they are separate disorders. However, if anything, it should heighten us to ask about these problems during our postpartum counseling, or ask about these issues during our pregnancy history when we take it in our cardiovascular world, so that this may uncover some risks that we are not aware of. So what is the relationship between preeclampsia and peripartum cardiomyopathy? And these are, a very nice meta-analysis by Natalie Bella from Columbia that looked at about 22 different studies that had, a strong association of preeclampsia with peripartum cardiomyopathy. One must recognize that the background prevalence of preeclampsia is about 4 to 5%, but in these studies, prevalence of preeclampsia in peripartum cardiomyopathy was 4 times higher than the background population. So again, that really should alert doctors about asking preeclampsia history in women that we see with peripartum cardiomyopathy, or better still, when women are developing preeclampsia, to actually have a very high index of suspicion to rule out peripartum cardiomyopathy in these women. So can we predict recovery in peripartum cardiomyopathy? This was one of her questions to me. Is there something that we can do that helps identify women who are at risk, who likely will not recover their LV function? And so the prognosis of peripartum cardiomyopathy is better than other types of causes of dilated cardiomyopathy, but in no ways is this minimizing the significant effect of peripartum cardiomyopathy on women. And I think this is data from Dennis McNamara's group at Penn. This was a multi-center IPAC study, which was prospectively enrolling women in the United States with peripartum cardiomyopathy on guideline-directed medical therapy. And they found that the EF at development of their index peripartum cardiomyopathy was strongly associated with prognosis and strongly associated with recovery patterns. And what they found is that if women had an EF of less than 30% on their index presentation, they were more likely to have complications and more likely to not improve in the 1 year postpartum, as compared to women who presented with EFs greater than 30%. So EF can be an important prognosticating tool in these women. And this is data that just came out literally in this month from the ESC. This is the ESC prospective multi-center registry looking at several different regions. About 700 women were enrolled in about 50 countries. This is one of the largest Peripartum cardiomyopathy registry. And they looked at what are some of the risk factors and risk features of these women. And there were many, many regions that were isolated here: Asia, Africa, Asia Pacific, Middle East. And compared to other registries in the United States, which largely have had Caucasian women, this had a really improved racial split. And 28% were Black, and 13% were Middle Eastern, 28% were Asians. What they looked at was that this is not a small problem. At about 6 months, 7% had thromboembolic complications, 6% were associated with mortality, with 30% associated with sudden cardiac death. Readmission rate very high, especially with heart failure and heart failure related issues. Myocardial recovery only in about 50% of these women. So these are women who can be very young with persistent severe LV dysfunction. And there was a major regional variation as well in this, with women in Africa having less recovery. Neonatal mortality was significantly high. So this is by no means a small problem. And so what are the factors that affect poor prognosis? Phenotypically, we talked about LVEFs and LV dilatation. Degree of RV dysfunction has been shown to be associated with poor prognosis and poor recovery. Association of gadolinium on MRI, obviously, scarring and fibrosis. But again, women with family history of idiopathic cardiomyopathy are at high risk of developing peripartum cardiomyopathy, something that we should be taking in our history. In women with peripartum cardiomyopathy is whether or not they've had family members with dilated cardiomyopathy, because there is a strong association with the titin gene, which is the TTN truncating variant of titin, which is a core filament of the myocardium, where having this gene in the genetic mutation, either splice variants or other variants of the TTN gene, are strongly associated with poor prognosis and poor recovery. And in fact, many believe that this is a second hit phenomenon, where a woman who already has the genetic mutation goes by her life until she gets pregnant and then develops full-blown cardiomyopathy. So something that we usually do in peripartum women is to screen them for this truncating variation and genetic mutation as well. So sort of identify other family members who may be carrying this problem. So lastly, how can we improve competencies in cardio-obstetrics, right? Because we talked about maternal mortality, we talked about pregnancy-related deaths, we talked about the fact that most of the pregnancy-related deaths from cardiovascular causes are preventable. We talked about the fact that there are provider factors, and yet we don't teach this. There is no cardio-obstetrics service line in many hospitals and many health systems. There is no COGATS requirement. So if we're going to meet the challenges of this problem, I think we're going to need clinicians who are competent in cardio-obstetrics, who recognize this. This is a multi-pronged approach. We really need to be able to revise our education, improve our training in cardio-obstetrics. And this needs a revision and incorporation in our COGATS. Whether or not we are competent to recognize the pharmacotherapeutics of pregnancy, pathophysiology of pregnancy, APOs. I think it starts with cardio-obstetrics curriculum and cardio-obstetrics training, but we also need to improve basic translational and clinical research in this area, because there are several unanswered questions. A lot of this will guide what to do with these patients. In the last couple of years, the educational resources around cardio-obstetrics have improved much to the relief of aficionados of cardio-obstetrics, but really for a person like me who is developing a niche in this area, this is a huge step forward. And I think recognizing that this is an unmet need and sort of improving our scientific sessions to reflect this unmet need is really important. But also advocacy, patient advocacy, physician advocacy around cardio-obstetrics in improving health education and promotion, and stakeholder partnerships so that AHA, ACC, ACOG, SMFM all join together to release consensus guidelines and help improve the care of these patients, but also improve the knowledge base of their members. And the importance of cardio-obstetric clinics cannot be further stretched. I mean, these clinics are super important for these women so that preconceptional counseling, access to care issues, close monitoring during pregnancy and postpartum timeframe is really, really important. if we are to sort of make a change in where these women are going with their lives. Role of Pregnancy Heart Team. This is a paper co-authored by Gina Lundberg from your institution that looks at the importance of Pregnancy Heart Team and what it can do in terms of pre-pregnancy consultation, delivery care, as well as a long-term care in some of these high-risk groups. I think we need to recognize that there are several members of the Pregnancy Heart Team, of cardiologists, obstetricians, maternal fetal medicine doctors, obstetric anesthesiologists that are highly important, and specifically the WHO class 3-4 heart failure category women that can have significant obstetrical complications and delivery complications, a geneticist, social worker, all. This is teamwork. And what can cardiologists do? So what can you and I and our next generation of FITs and early career members do about this? And, you know, I leave this here, it's still pretty raw for many of us. Fight for the things that you care about, but you have to do it in a way that will lead others to join you. And I think that cardiologists themselves can't really turn the trajectory of these women. We have to really improve access to care and have to join forces with other other societies that are really legislating this. And in the words of Nanette Wenger, yes, you have to investigate, and yes, you have to educate, but you also have to advocate. And I think that Medicaid expansion of postpartum care, so that women who lose access to healthcare are still given the opportunities to be able to see their physicians and providers, especially since we've talked about the predominant problem in these women after they deliver. And so California recently became the first state for Medicaid expansion. And there are many others that are actively legislating this, including Georgia, which has at least one step forward in the game. So back to my patient, this is shared with her permission. We had multiple consultations and very close follow-up. I've been following her now for 2 years. She's not on any aspirin anymore because our current prevention and cholesterol guidelines will not indicate the use of aspirin in this technically low-risk woman. And I think the data is still out there as to what to do with these women and how long should we continue aspirin in this time frame. She'd asked for a calcium score. It's again not indicated. It's 0 in her. She's on a plant-based diet. Hemoglobin A1C is normal. Her echocardiogram actually has improved, and now she's asking me whether or not she can come off her guideline-directed medical therapy, which is another, Pandora's box in this women as to when to take them off their guideline-directed medical therapy and how to take them off once their cardiomyopathy improves. But she's very happy. She has 3 young children and is doing really well. And so lastly, and the summary slide, which is what I started off with first, is that cardiovascular disease is really important. We need to recognize this. We need to recognize the knowledge gaps. We need to recognize the relative contributions of APOs, and then work towards changing the course of these women. Thank you.
Thank you, Dr. Sharma. That was outstanding and such a great review and summary of what you've been doing at Hopkins. I'm going to open this up for questions. Please send me questions, either text me or type them in the chat box. I'll start off with a question that Dr. Lundberg asked. She said, do you think that we should be learning cardio-obstetrics as a subspecialty within cardiology, or should general cardiologists just be learning about all this?
Yeah, so, I often get asked, this is such a great question because we keep adding different specialties to our training. And now, I think if this was taught as a module since medical school, I think a lot of our knowledge gaps would be completed, would be like filled, because not just cardiologists, primary care doctors are also taking care of these women. So I think teaching it from the medical school onwards is important. I do think that having a focused curriculum within cardiology, within the 3 years of cardiovascular training on some important pharmacotherapeutics, pharmacologic problems, genetic problems, and other cardiovascular problems in pregnancy is really, really important. These women are out there. I can talk from my experience. I had very limited exposure to them when I was training. Much of what we learn is learning by doing. And so I would hope that there would be a special focus on this. What you have at Emory with the Women's Heart Center is a classic way to sort of expose these women to trainees, where you have specialized care and they can come in for their multiple rotations to come in, be involved in not just treating them, but also learning certain important topics. Hopefully it will change. It has started to change, but certainly a really hot topic, and most institutions are saying that this is the cardio-oncology of 5 years ago. So I think more power to the cardio folks.
Great. I do have another question about the molecule that you mentioned, the biomarker SFLT1. So tell me a little bit about that. Is that something that rises in pregnancy and then goes away? So like if we were to check our blood now, does it stay persistently elevated, and does it predict prognosis?
Yeah, so that's such a great question. So SFLT is a soluble form of tyrosine kinase 1. It is a derivative of angiotensin A2, and actually is now being recognized as a biomarker that helps identify endothelial dysfunction in women with preeclamptic pregnancies. It's also seen in other cardiomyopathies, including peripartum cardiomyopathy. So the role of what SFLT can do is still sort of being uncovered. It's being used as a biomarker test and increasingly being studied as something that can be used in these women. SFLT should not increase. If your SFLT increases during pregnancy, it is a sign that there is placental dysfunction. There is pathogenesis in the placenta where there is likely endothelial dysfunction. And that SFLT placental growth factor ratio of greater than 38 is the cutoff, where you have, the higher the ratio, the higher the likelihood of developing preeclampsia. And it has been well studied. It is actually being studied in the United States in a large NIH trial. In terms of your question as to what happens postpartum. So there is actually a rapid decline and drop once the placenta goes away. But there are other data that are coming out that some of the SFLT can persist. And whether or not that persistence and the level of persistence and how it is associated with indicators of vascular endothelial dysfunction is still unclear. And in fact, my research is focused on SFLT placental growth factor ratio and subclinical myocardial injury. So we're looking at strain as well as myocardial work parameters in preeclamptic women with SFLT. And then we hope to bring them back after they have delivered and sort of understand what happens to this ratio and whether or not it rapidly declines. So more research to come. There's a few centers that are actively studying that as well.
Very interesting. Good luck with that. I look forward to hearing what you have to say next year about this. On a related question, Dr. Taylor says, thank you for a very nice seminar. And he says that there was a flurry of data in the past about activating autoantibodies to angiotensin II receptors as implicated in preeclampsia. And so can you, is that still something that's viable?
Yes, it is very, very viable. And in fact, one of my colleagues is actually studying that biomarker and its indication in subclinical myocardial dysfunction during pregnancy. So we're kind of neck to neck trying to find out which biomarker is more indicative. But SFLT is thought to be a derivative of A2. So I think they're all both linked, and that's really, figuring out which one at what time in pregnancy is sort of something that will evolve. So that's an excellent question, and that is still being studied very actively, and especially at our center.
Okay. Dr. Izidenzo has a question so in general, patients who develop pregnancy-related hypertension, how long should we be following them postpartum for their hypertension? If they have to be eventually weaned off, what's the follow-up?
Excellent question, Ijeoma. So, recognize that there's now data that 40% of these women who develop pregnancy-associated hypertension don't even follow up postpartum at their 6-week visit. There is a huge drop-off. And in fact, there's data that tells us that the peripartum strokes and the postpartum strokes are highest in these women. They come back in with hypertensive crises and often, postpartum strokes because of loss to follow-up. I think the question is how long to follow up. I mean, most women will be still hypertensive at about 3 to 6 months postpartum. About 50% of these may still be hypertensive. So definitely expanding that. And, either with the help of APPs or home blood pressure monitoring or telemedicine, having, sort of a patient-centered platform where these women can log their blood pressures and titrate their medications and be aware of the signs of postpartum stroke is important. At about 12 months postpartum, about 10% of women will have chronic hypertension. So I think expanding care and seeing them at about 3 to 6 months as a cardiologist, and then maybe another 6 months later would help pick up most of the high-risk women. And that's what we're doing in our center. We see them once through telemedicine at about 2 weeks, only to talk about health promotion and taking their blood pressure. And then we see them after they've been released by MFM at about 3 to 6 months time frame. And that's where crux of our prevention actually happens. We'll look for hypertension, we'll look for other high-risk features such as lupus, and screen them for it. And then if they don't develop chronic hypertension, then most of them are okay, and we usually release them to their primary doctors.
Okay. There's a question from Dr. Sharma. He's asking, so if somebody has preeclampsia, when do you suggest not getting pregnant again?
Yeah. So we don't suggest not getting pregnant. We just say you're very high risk, and that puts you in a risk category of developing a subsequent APO. It's still out there as to what to do with these women and what to look for, and how to better risk stratify which preeclamptic women can have a subsequent preeclamptic pregnancy. I think some of that is being studied. But sort of having a conversation with these women saying, let's look at what your blood pressure is postpartum at 12 months or maybe even 18 months. Let's space your pregnancies out. Let's talk about other risk factors that could be contributing to preeclampsia, whether or not you're pregestational diabetic or diabetic, or you have comorbidities such as obesity. What can we do in sort of trying to reduce those other traditional risk factors in this time frame will really help these women. But I, in my practice, usually say you're high risk, especially if you're at extremes of age, either you're too young or too old, and that, this is sort of an individual shared decision-making. Some of these women of note, Dr. Mehta, are severely traumatic, post-traumatic. They have severe post-traumatic stress because they've had such bad complications from their pregnancy where they've had fetal death, fetal morbidity, small for gestational age infants who are in the ICU or the NICU for a long time. And I think the medical community needs to recognize that they're still dealing with a lot of issues postpartum, and having that support structure for them is essential so that they can bounce back and really take care of the kids that, that were born.
Great. Thank you so much. That was really, truly outstanding, and we really appreciate your time this morning. It's 8:30, so I'm going to close Grand Rounds now, and I will see everyone next week. Thank you so much.
The preceding program is copyrighted by Emory University.